Business Pharma and the panelists, behalf of panelists, we are warmly welcoming you for this program, especially for the benefit of the educational purpose for the postgraduates. And one second. For the first program, the talk is given by Dr. Rama Devi TJ. Doctor is a present HOD and consultant in Kimshealth Trivandrum. And Madam has given 6 publications and many in national conferences also. And Madam is IADVL Central Council member, Joint Secretary ACA 2001 to 2003. And she is Organizing Secretary, Derma South Zone 2019. And Madam is a Dermapathologist 2016, QT and Kerala 2012. And Madam's area of interest is clinical dermatology, pediatric dermatology, rheumatology in dermatology, cosmetology, lasers, injectables, and peels. Now I am warmly welcoming Ma'am to give her wonderful talk.
Thank you, Naveen. At the outset, very good morning to all of you, and especially to the pharma officials who has created this platform for us, and also to Dr. Rajesh Shikri and Dr. Vinu, and also all the postgraduates who are attending this program. I'll just start sharing the screen. So my talk is just concentrated around how I utilize the combination therapies in the treatment of facial melanosis. And I'm working in a corporate setup where there are a lot of patients, and I'm sure you'd understand that many of the patients are quite demanding, and they just want instant cure. They want instant results, and it's not very easy to convince them or to motivate them to do procedures, and also to tell them that this is the best result you can get out of this procedure. And many of them may not be really compliant in avoiding sun or wearing sunscreen regularly or sticking onto your prescription. So that makes treatment all the more difficult. But still, facial melanosis is a big subject, and there are a lot of conditions which can cause facial melanosis, and we need to have an overview about all these conditions. And if you see that many conditions will be, many of the conditions will have treatment overlapping with each other. A combination of treatment is always better than using an isolated modality, whether it be a topical medication or whether it be laser or whether it be peel. I think it's always a combination of the treatment is which is going to bring about a best outcome for that particular patient. So you look at the types of pigmentation. It can be broadly classified into epidermal, dermal, and mixed. Mixed will have both epidermal and dermal component. Broadly, the epidermal lesions can be freckles, lentigines, and Kaffir macules. And epidermal lesions are classical in presentation, and they have a predictable response to treatment. Dermal melanosis, congenital types would be nevus of Ota, nevus of Ito, blue nevus, and Mongolian spots. And also the acquired conditions, dermal melasma, Horis nevus, which is otherwise the acquired bilateral nevus of Ota-like macules, and lichen planus pigmentosus versus Erythema Dyschromicumperstans, which is very common in our practice and also something which is very difficult to get under control. Histologically, melanin granules can be seen in the dermis, the melanophages, or the nevoid cells in these conditions. And they seldom respond to topical therapy or aesthetic procedures like superficial peels. They respond, but the results may not be consistent. So there are a lot of other important factors like avoiding sun and wearing sunscreen and sticking onto the topical therapy. So with 1 or 2 procedures, you may not get a complete cure or even a complete control of the condition. Lasers has got something more to do with the pigmentary conditions. They've got precise selectivity. They've got a depth of penetration depending upon the type of laser and for the particular condition. And there is an ability to spare the epidermis. So more and more doctors and consultants are using lasers over peels nowadays. Of course, peels are always an integral part. Topical therapy is an integral part. Lasers have really come into practice in the treatment of pigmentary conditions. If you look at what is the promoting or triggering factor, it is UV exposure. Both UVA and UVB can exert its action depending upon the skin compartment. UVA penetrates deeper and affects the dermal connective tissue also. Oxidative stress, increased pigmentation, and modulation of genes are the other effects of UV exposure. Increased pigmentation can also be due to the phototoxic oxidation of melanin and melanin precursors, and this situation is much more pronounced in the darker skin when compared to the light skin. So in addition to the oxidation of melanin, it can also produce oxidation of the melanin precursors also. In addition, UV exposure can result in reorganization of melanosome in the upper layers of the skin. This again is much more in the skin of color or in the darker skin. So overall, a UV exposure can definitely aggravate the depth of pigmentation and visible dark color. These are the common facial melanosis we come across in our day-to-day practice: melasma, Reels melanosis or pigmented cosmetic dermatitis, poikiloderma of civet, erythromelanosis follicularis of face and neck, Erythema Dyschromicumperstans, lichen planus pigmentosus, periorbital pigmentation, which is very common, acanthosis nigricans, which has a facial component, post-inflammatory pigmentation, exogenous ochronosis, nevus of aorta, peribuccal pigmentation of Brock, and drug-induced pigmentation. This is just a patient of mine showing maturational pigmentation, which is otherwise facial acanthosis nigricans. Erythema Dyschromicumperstans, all of us should be seeing enough number of cases. I'm from Kerala, Trivandrum. Here, the craze for hair growth is definitely more like in any part of India or any part of the world. So people try out many medicated oils which they see in advertisements or in YouTube channels. The end result, quite often what we see is this. Erythema Dyschromicumperstans versus lichen planus pigmentosus. And on the right-hand side, you can see the nevus of aorta. Here you can actually see the confirmation. You can see the pigmentation on the sclera as well. Am I audible?
Doctor.
Yes, Doctor. Am I audible?
Yes, doctor. Yes, doctor.
Yeah,
yes, doctor.
Okay. Facial acanthosis nigricans again in a lady. You can see that the same patient has got acanthosis nigricans of the neck. Melasma in a Keralite lady. You can see the brown pigment, which shows that it is more of a dermal melasma. We can also see hypopigmented areas in between, which is possibly secondary to the multiple modalities of treatment done, or some of the individuals may show confetti-like hypopigmented macules. It is said that pathologically in those areas, the vascular component may be absent. This is one problem with like when you start treating the patient, they may have this prominent hypopigmented macules and patches within the melasma patch. This is a Middle East lady with a dermal melasma. Again, melasma, more of an epidermal component on the forehead. On the right-hand side, there is again melasma over the cheeks and also extending onto the forehead. This is post-acne pigmentation, very common occurrence, which we see quite commonly in our practice. Much more easier to tackle when compared to the other causes of dermal melanosis or melasma or erythema dyschromicumperstans. Periorbital pigmentation is a very tricky situation because when you see periorbital pigmentation, you should ask a patient to stretch that area of under the lid area so that we can make out whether there is an actual melanin component or whether it is only contributed by the shadowing effect or by the wrinkling effect of the skin. You can see in addition to the melanin pigment, she has also got wrinkles, which is making that area much more darker. So let us coming to the quickly coming to the overall broad treatment methods. Still, all over India, I mean, all over the world, people are moving away from hydroquinone, but still there are authorities who are still using hydroquinone as the first modality of treatment so as to get a quick reduction of the pigmentary mode. Like I personally, I have not used hydroquinone for the past around 15 to 20 years because initially I've had some bad experiences, so I've stopped using. But still, if you look at any textbook or any journal or any review article, hydroquinone can be seen. It is still included in the modality of topical therapy. And these are the possible combinations which you can combine with hydroquinone. Or if you look at the left-hand side, you can see hydroquinone, mequinol, tretinoin, azelaic acid, kojic acid, niacinamide, ascorbic acid, licoritin, soy. These can be combined with the other agents which are seen on the right-hand side column. These are the possible combinations we use. But in my practice, and I'm sure in all our practice, we are using more of tretinoin, kojic acid, ascorbic acid, and of course, glycolic acid, licorice, salicylic acid, etc. as a combination and less of hydroquinone. That is what I personally feel. Now, coming to these are the combination of like agents which we can use. And definitely the choice of the agent depends upon the condition, the depth of pigmentation, the sensitivity of that particular patient's skin, and ultimately it is a choice of the dermatologist, and the dermatologist chooses the topical agent very carefully so as to bring about a rather it's should be something like an overall control of the condition rather than a quick improvement followed by a flare. Chemical peels form a very important modality in the treatment of pigmentary disorders, and they are reliable skin surfacing modality. Not only for pigmentation, it's also used a lot for wrinkling and photoaging. And here again, the agent and the concentration determines the depth of the peel. Peeling agents can produce exfoliation. They can actually remodel the collagen, as well as it can produce skin lightening. So Fitzpatrick types have to be considered when you choose a type of the peel. Here again, type 4 and type 5 are more prone for dyspigmentation. So when you choose a high percentage TCA for a darker skin color, be careful. They can produce inflammation, and immediately there can be post-inflammatory hyper or hypopigmentation. Always use a low-strength TCA. These are the peels which I use. I mean, I work in a corporate setup, and this is a peel. One peel which we use as a milder peel for any type of, confidently is something which you can use for any type of skin. Combination of 20% arginine and lactic acid. Then salicylic acid, mandelic acid. Only thing is that salicylic acid produces quick frosting. So you have to tell the patient well in advance while doing the procedure itself, you will experience a burning sensation, and there can be white frosting, which when you wash off, it will go away. And if at all there is a erythema, we are going to apply some steroid cream. It will subside in a day's time. And salicylic acid, mandelic acid combination, 22 and 20%. This is the same arginine peel. And TCA 15% is something which you can again choose confidently for any skin type. The only condition, there should not be any broken areas of skin or any, eroded areas, because this is a prerequisite for choosing a peel. Skin should be free from inflammation. So 15% TCA is a safe peel. Yet another peel which we're using is black peel. This contains actually jasmonic acid and black acetic acid with a little bit of salicylic acid. It's a good peel. It's expensive, but it is very good to, I think, contain the facial melanosis. The last one is Retisser CT peel. This is actually brand name. I'm sorry to put up the brand name here. This contains actually one thing. It contains an ampule of vitamin C, and also it contains cream with retinol palmitate and retinol. So what it does is it reduces the pigment as well as produces peeling. Usually it produces a uniform peeling, and the peeling subsides in a week's time, and it can be actually contained by applying moisturizers. So this gives a long-lasting result, and this can be repeated once in every month to reduce like intense pigmentation, or even this is also used for improving the texture, and also in patients with active acne also, especially grade 1, grade 2 acne, the comedones can also get loosened, and it can produce a remarkable difference in the improvement of acne. And this is the peel with retinol and vitamin C. Now, just want to show what all like combinations. Here you can see the patient. This is with a combination of trichloroacetic acid peel, salicylic acid mandelic peels, sunscreens, which are very important, plus I also did a HYDRAFacial for this patient. HYDRAFacial is a procedure in which you cleanse, you extract, you again cleanse, and cleanse, you apply a peel, then you extract the sebum, then again you cleanse, and after that you apply vitamin C or other depigmenting cocktails, followed by derma builder like a collagen modulator, followed by an antioxidant. There are different steps. It takes around 30 minutes. It is expensive. Everything should be explained to the patient well in advance before you do HYDRAFacial. So if you do all these things in combination, the results are much better. Here again, patient with dermal melasma, there is a mild lightening, dermal and epidermal component, but epidermal component is slightly less. Dermal component is still there. Here the combination used was TCA, then arginine lactic acid peel, and of course, sunscreens. Another modality which I commonly use in facial melanosis is laser. And lasers are mostly, it is usage laser. And intense pulse light is also in use, but you have to be very careful when you use intense pulse light. When you do laser treatment in darker skin, make sure that there is enough sun protective clothing and sunscreens being very regular. And patient has to be explained regarding the use of laser and the post-procedure care also. A priming of the skin for 2 to 3 weeks before therapy would be ideal, but when many patients come forward asking for a quick treatment, the priming part may not be very perfect. So warn the patient of a post-procedure hyperpigmentation, peeling or hyperpigmentation before laser treatment. So you can also choose a small area and do a test treatment before you go for a larger area. Individualize the treatment parameters for the particular condition as well as for the particular patient. A large spot size and a low fluence should be used in darker skin types, because even if there is some amount of inflammation, it will produce only some mild pigmentary changes, but not burns. Avoid stacking whenever you do it on a darker skin area. Even on a normal lighter skin, the stacking with the laser is not very much advised. While doing the procedure also, you can provide either air cooling or you can provide ice packs. Usage NTAG laser is something which we regularly use. It can be used for both epidermal, dermal, as well as for the mixed. And one good thing about this usage NTAG is that it targets a melanosome because of its ultra short pulse width and the adjustable spot size. So you can adjust the spot size, you can adjust the energy and aim it onto the particular lesion. And ideally, what we use for the dermal lesions is 1064 nanometer. Laser toning is a very popular method which we can even use for melasma. You can actually use very low fluence multiple passes at weekly intervals. Initial studies and all showed in weekly intervals, whereas later on, when these patients were followed up, like it was said that like possibly the weekly intervals need not be done because there was a chance of rebound. So possibly the interval between the procedures could be lengthened. What does it do? It produces subcellular selective photothermolysis of the stage for melanosomes. As such, when you do laser toning with a low fluence, there is no cell death. So the inflammation is less and the recurrence rate is also low. Motile hyperpigmentation. Hyperpigmentation can be seen in some individuals, especially after repeated sessions. So if you increase the period, like once in 2 weeks or 3 weeks, this can be reduced. That is what theoretically said. But I have seen patients reporting back with this hypopigmentation. And laser toning also, if you want, you can combine it with the triple combination therapy. Again, I am generally known for triple combination therapy. And also you can use it with IPL. Again, IPL, you have to be very careful when you use it on a darker skin. This is usage NTAG laser. What we use is a Stellar M22. This is a new machine and we have just started using within 6 months. Large spot size with longer intervals are effective. One thing is that when you use for all this deeper penetration thing, the motile hyperpigmentation, which you have to warn it to the patient, otherwise they'll come back with a lot of complaint. So mixed melasma treated with usage NTAG. She also underwent chemical peels earlier. Overall, the pigmentation is less, but you can still see a foci of pigmentation on the malar area. This is a stellar IPL with all the type of small filters you see are for different indications like vascular, acne, photo rejuvenation, etc. We are only started using this. Just want to show you that, see, when intense pulse light is done for a darker skin tone, this is what which can happen. You can see the intense inflammation and the peeling of the skin. Fortunately, the patient was very cooperative and I had warned her, but still even with the low fluence, you can see the degree of inflammation and peeling. You can see the severe hyperpigmentation post-procedure a week later. And then finally, you can see that there is definitely reduction in the pigmentation. But still, that interim period, 1 month, you will also be very stressed. This is mesotherapy, where I think many authorities use it with electroporation. We don't have the electroporation. We inject it intradermally. It's a skin lightening solution which contains vitamin C glutathione solution. So these are, this is one, actually, I don't know whether you can appreciate. This is taken by Samsung S22. So generally it lightens up the whole day. This area had a pigmentation because he applied Colgate toothpaste on the pimple. And this was the result. And this is just soon after mesotherapy. And this is another picture you can see. This area, there's some slight lightening. HydraFacial equipment, expensive, not suited by everybody. It's only because of the expensive nature. Even the consumables are very expensive. That is why as time goes on, the expense for the consumable also goes up. So in our setup and all, we are forced to charge even more than 7,000 to 9,000 per sitting because of the expensive consumables. Not really suited for all patients, but definitely in combination, it can be used. Post-acne pigmentation, I told you know how a combination can work. Look at the acne with pigmentation. Look at the smooth skin now. This is with combination, TCA peel, salicylic acid, mantelic acid peel, and erbium glass laser. That is popularly called the luminous. We have the luminous resurface laser, 1550 nanometer erbium glass. This is what gives you a combination. Epidermal melasma predominantly, epidermal melasma reducing after the combination of TCA and topical vitamin C, but still you can see a focal area of pigmentation. And with this, I just conclude my talk.
Thank you, Doctor.
So any questions?
Thank you for the lucid presentation for the understanding for PGs. Any questions, kindly you can ask. The PGs are themselves, they can unmute and they can ask questions. Or else you can put it in the chat box also. Okay. Okay, Doctor.
Can I stop the
Yes, madam. Yes, madam. Madam, one question. They put it in the chat box, madam. Drugs, 1 second. The question is, Dr. Zuzu.
Drugs for facial melanosis. Are you talking about the oral medications? What in my practice, I give oral antioxidants. You know, we have ready-made combination of vitamin, retinoid, beta carotene, vitamin C and vitamin E. I give vitamin C also, except in patients whom you feel that have got some taking too much of blood thinners and all, I don't give. But otherwise, I give vitamin C, 500 milligram morning and evening for a period of 2 weeks. And in those people who are very concerned about the pigmentation, I even give a short course of oral glutathione. Order of topical application of melasma sunscreens, number 1. Second thing is a combination depigmenting agent without steroid and without hydroquinone. Use a combination of kojic acid, arbutin, or kojic acid vitamin C. Start off in a mild manner. Even if it is kojic acid, it can produce irritation. Asam to apply it for a short period, wash it off and apply moisturizer. Gradually increase the contact time, and then once it reaches around 1 week or 2 weeks, can apply it overnight. And then, of course, all the other, even retinol has got a action for melasma. It actually removes the melanized epidermis. So I think you can use a retinoin or retinol containing preparations. What works best for dermal melasma? I think peels. Peels plus sunscreen. No, I have not used Cosmelan. Cosmelan, many of my friends are using. They told me they get excellent response, but definitely there is a rebound.
Yes, madam.
If you
I
are
think
failing in the advice regarding sunscreens, definitely you are not going to get a good result at all. Many of the patients, I tell them, you keep the sunscreen with you even in your workplace. Please put an alarm in your mobile and apply it at least once in 2 to 3 hours. If you're not applying the sunscreen regularly, whatever treatment you do, you're not going to get. See, patients are looking at only the results. They don't want to know whether you're using tranexamic acid, whether you're using kojic acid or arbutin or whatever it is. No, they only look at the facial pigmentation. The very next week, if their friend says, no, your pigmentation is more, they lose trust in us. They lose trust in the medicine. They'll quickly visit another doctor. We will lose a patient, of course. Losing patient is not the main thing. But see, ultimately, when they call you and say, doctor, the pigmentation is more, you feel totally dissatisfied. So talking to them pre-procedure, explaining in detail is very important. Tranexamic acid, of course, I don't give intradermal, I give only topical. It works, but let me tell you frankly, it does not work alone with sunscreen. You have to use another topical depigmenting agent like kojic acid, arbutin, or vitamin.
Thank you, madam. The pages have been benefited from your talk, how I utilize combination therapies, facial melanosis, madam. And you patiently answered for all questions. You have lucid and extremely you shared your experience to our pages, madam. And thank you so much for a wonderful talk, madam.
Thank
Now
you. Thank you so much for this
introduce
platform.
our next. Thank you, madam. So, thank you, madam. So for our next session is taken care by clinical. The topic is clinical pathogenic correlation by Dr. Rajiv Shekri, MD, Dermatology, Fortis Hospital, Noida, former research associate, AIMS, New Delhi, and combinedly the topic will be given by Dr. Vinod Shekri, MD, Dermapathologist, Fortis Hospital, Noida. The doctor is a fellowship in dermapathologist in Thomas Hospital, London, University of Graz, Austria, as well as Boston Medical University's Boston. So I am welcoming both doctors, Dr. Rajiv Shekri as well as Dr. Vinod Shekri, to give their wonderful.
Thank you. Thank you. So we share our screen, please.
Yes, doctor, you can share, doctor.
This is a very clear-cut case of granuloma annulare. You can see these annular lesions with central clearing, and the lesions are formed by tiny grouped papules, and there are no additional findings, no scaling, no itching, asymptomatic, just annular lesions on the different areas, and it is a case of granuloma annulare. This is very clear. You can see on the hand even. Then again, you can see on the arm, on the chest, you can see these annular lesions, annular lesions, annular lesions, tiny grouped papules, asymptomatic, and these are granuloma annulare. So again, you can see on the limbs, the annular lesions on the upper chest, on the back. These are the irregular annular lesions, irregular annular lesions, and there is nothing wrong. These are all granuloma annularis. And this is the case, very interesting, that you can see these are the annular lesions, these are the annular lesions, these are the annular lesions. And this case was shared by Dr. Rakesh Bansal, that this patient in April 19, 65 years female, developed 1.5 months ago, forearms, hands, upper back, and chest, these annular lesions, and the clinical diagnosis of granuloma annulare was made. Then the Dr. Bansal asked the question to the patient that anything in the background. In 2018, the diagnosis was made of the systemic sarcoidosis, and she was on periodically systemic steroids. So Dr. Bansal thought that, am I dealing with cutaneous sarcoidosis, which is mimicking granuloma annulare? Then the histopathology was done.
So this is the histopath, and the epidermis is showing some hyperkeratosis. Otherwise looks normal. It is stretched over the dermal infiltrate, and the dermal infiltrate is kind of elliptical, and it has all these very pale staining cells which are histocytes or histocytic in nature, And there is the central area which shows very subtle necrobiosis. And there's also a perivascular lymphocytic infiltrate. So, putting everything together, it fits in very well with GA.
So when it is histopathology is saying that it is granuloma annulare, so this is the case where systemic sarcoidosis was associated with granuloma annulare. Then we looked into the literature, and there are few publications to say that this is a rare scenario where systemic sarcoidosis and granuloma annulare can coexist. So this is the patient who reported to us. She is 76 years. On 10th August, she developed these annular lesions on the arms, on the face, and they were all. I thought, oh, they're GA-like. So am I dealing with GA? My only concern was, she says, sudden onset. Otherwise, GA is a slightly slow to develop. So she said sudden onset. But when I see the lesions closely, you can see these are. She was not having any itching, and central clearing is there. Central clearing is there, and the lesions are annular, irregular in shape, and they are formed by tiny papules. So here also you can see clearing of the lesion and the tiny papules, irregular in shape, even on the forehead. So, but sudden onset, so that was my concern. But yes, it is granuloma annulare. I can't say, oh, no. So, I made a diagnosis of generalized granuloma annulare, and then we took a biopsy from this lesion. So, this was the lesion, we took the biopsy.
So this is the biopsy from the arm lesion. The epidermis is pretty much normal. There is compact orthokeratosis. And in the dermis, there is a infiltrate. And at this power, we can see that there is a central area with some little bit of mucin and pale cells surrounding this central area. There is also an interstitial infiltrate here and there, and a mild perivascular infiltrate. This is another field showing the same picture, and this is also the high power. So we see these pale histiocyte-like cells. Along with these pale cells, there are these small cells with very bright cytoplasm. These are the eosinophils. So we have a mixture of histiocytes and eosinophils in this dermal infiltrate, and they're present in a palisade-like manner with admixed eosinophils, and also interstitially we are seeing histiocytes and eosinophils. Now the question is, although it does look like GA, do we have eosinophils in GA? Yes, we can have eosinophils in GA, but in this patient, the number of eosinophils is pretty impressive. So here's another group of eosinophils, another group here, and then we have eosinophils in a good number here also. So then I started wondering, is this just EA or is this a drug reaction, which looks like GA? So another field showing lots of eosinophils along with these histiocytes. These are the histiocytes with pale light blue nuclei and pale cytoplasm, and lots of eosinophils everywhere. So the final diagnosis that I made was it most likely is GA-like drug eruption. We did a literature search, and the literature says that the pattern is that of interstitial GA, but in our case it was more of a mixed pattern.
So GA-like drug eruption is not very common. It is a rare scenario. So this patient in the June, she started angiotensin receptor blocker, and in August, she developed this GA-like eruption. On 10th August, she comes for the consultation and the biopsy was taken. On 16th August, we made the diagnosis that it is GA-like drug eruption. So we withdrew the drug and we gave no steroids. Only antihistamines were given, loratadine. And what we see on 10th October, when she comes back for the follow-up, you see the difference? On 10th August, she comes. 16th, we release the report and advise the antihistamine only. On 10th August and 10th October, exactly after 2 months when she comes back, and now let us see the results. On 10th August, she has this active lesion, drug withdrawn, and you can see the lesion is almost clear. You see on the arms the active lesion on 10th of August. You can see the active lesion, and after withdrawal of less than 2 months, 1 month and 3 weeks, you can see this. The lesions have practically, you can see, compare it, they are dissolving very well. Even on this arm, you can see the lesions are dissolving very well. Then, by mistake, she started the medicine once again, and let us see what happens. So on 10th August, first visit, lesions, drug was withdrawn, improvement. By mistake, she started the drug again on 20th of December, and on 3rd January, you can see the reappearance of the lesions. You can see the reappearance of the lesions. You can see this annular lesion on the chin. On 3rd of January, reappearance. So what patient did? Patient did provocation by herself. Now, to prove that this is a drug eruption, it is considered that provocation test should be done. But as a clinician, if I do the provocation test and the patient lands up into, say, TEN or SJS, so why should I take a risk? So as a clinician, I will not do the provocation test. But this was by mistake done by the patient, and that is what we are sharing, that the lesion has reappeared. So similarly, on the arms, on 10th August, her first visit, withdrawal of the drug after 7 weeks, you can see the lesions are much better, and then reintroduce the drug, and on 3rd January, you can see the fresh lesions, the annular lesion is appearing on the arms. So the clinico-pathologic correlation, it is not granuloma annulare, but it is drug eruption, which is GA-like clinical expression, and it was confirmed on histopathology. So, any questions? I will be happy to answer. Any questions, sir, from the audience? Hello? Any questions?
You can ask questions, and also if you want, you can put in the chat box also.
Sir, can I?
Sure, please.
Okay, thank you so much, sir. It's a very interesting cases. And sir, like, is this the first occasion where you're seeing this GA? Because I think we are missing like this drug reaction, GA like.
Yes, we are all missing, because most of the time, the key point was the sudden onset of GA-like eruption. That was the, confusing to me. Yeah, GA is something which otherwise, it's not that over just 1 week, 10 days, 15 days, you might have generalized GA affecting the face, the
Yes.
arms, and the other areas. So that was confusing. But when you look closely, no itching. Otherwise, if there is a drug eruption, I expect some kind of discomfort, itching. There is no itching, central clearing. The lesions are like GA. Yeah, looks like GA. So is it GA? So this is Vinu is my wife, and she's a dermatopathologist. So it's a teamwork. So then she says, "Oh, it is the GA-like drug eruption." So this was, and then the provocation done by the patient by herself. So that was a great thing for us to prove that yes, it is a GA-like drug eruption.
Thank you, ma'am. Like that description was fantastic, and I learned a lot. Thank you so much. And it's a very interesting. So the provocation produced more number of lesions. It looks like that.
Yes, the lesions were more broader, and they were more indurated.
Doctor, one question in the chat box. Doctor, how did you taper steroid in this case?
I didn't give a steroid at all, sir. I told, so no steroid was given. It was only the antihistamine was given because this was the eosinophils in the histopath. So I could have given the steroid, but I thought the patient is not having any much of the symptoms. So let us see if I give only antihistamine and withdraw the drug and the patient improves, that will prove it. And that is what happened after the 7 weeks when the patient comes, and the patient was much, much better. So we didn't give a steroid at all in this patient.
Any more questions? And Dr. Dr. Abil Anil asked, can we get this PPT, doctor?
Sure, we can do the presentation wherever you want. Sure. Okay.
Any more? Yes, doctor.
Fine. Thank you.
Thank you so much, doctor.
And Dr. Rama Devi, we enjoyed your talk also.
For us, learning melasma, I tell you, it's like, I mean, we we do more of a dermatology, so it's very tough to learn. Yes, good. So we have
Thank you,
done
sir.
few things.
Thank you so much, sir.
Thank you so much, panelists. This was for my extent our gratitude in the platform of the Derma Talk to Dr. Rama Devi, TJ, and Dr. Raju Shikri, as well as Dr. Vinod Shikri, to as those who have shared their wonderful experience to the benefit of the pages. I hope all pages got benefited with this program. So we are going to conduct many programs like this. So kindly share this this knowledge sharing to your friends also, and ask them to participate in the forthcoming videos also. For the video will be edited and it will be posted in our Research Pharma YouTube channel. Kindly contact Research Pharma Field Force to get this video link also. It will take 2 weeks to be posted in the Research Pharma platform. And once again, we extend our gratitude to all the speakers who has given a wonderful presentation in our platform. Thank you, doctors. And thank you so much.
Thank you.
Thank you very much.
Thank you.
Thank you.